And there's a lesson, put up your best friend as the chairperson when you have to speak, because he is going to introduce you with some superlatives which you actually don't deserve. Thank you very much. It is a little unnerving for me to step into the shoes of likes of Dr. Siddharth Shah, Dr. Y.P. Munjal, Dr. Shashank Joshi, Dr. Rajesh Upadhyay, the path that they have treaded. And it's heartening that we've all assembled in Hyderabad to have a discourse on what medicine is today. When I was in fact thinking of the topic that I should give as my presidential address, I thought for a while that I'll show some of the interventions that I had done, some of the procedures, some acute myocardial infarction PAMI procedures at night. And when my colleagues said, are you becoming a president of some stenting association of India? I said, no, it's a physicians association. So they carved this beautiful topic for me, which says medicine in India challenges innovations and practices. But since I happen to be a cardiologist, I'm going to drift after a while towards my own field. But let's just see as physicians, you and I, what are the different problems that we face today in terms of this changing world, how we need to innovate, change our practices in the sense that we can serve the patient, which is the ultimate goal of any physician, that is to serve the patient in a better, in a more enabled manner. Let's see what the disease pattern today is in the world. The latest World Health Organization Global Status Report says non-communicable diseases today form a large fraction of diseases that we are encountering. 100 years back, we were fighting with infections, nutritional diseases, mother and child disorders. But the latest report shows 52% of the diseases that anybody in the world faces today is non-communicable diseases. Injuries form 14%, and some of these earlier diseases I just mentioned only form 34% of the world disorders. So we have a change, a drift in the pattern of diseases that we are seeing. Now, amongst these non-communicable diseases, which are the ones which are afflicting our population? Cardiovascular diseases form the largest percentage, 37%. Malignancies are coming up, increasing with increasing pollution in the diet and in the environment, 27%. Respiratory disorders form 8%, and diabetes, again a very common. So these four are grouped actually as the big four or the culprit four, which are responsible for the largest amount of ailment amongst mankind. We just heard Dr. Andrew Gurman speaking. In US, they have been able to reduce the prevalence of some of these disorders over the last 60 years. From 1950, diseases of the heart, cardiovascular system, neoplasms, diabetes, COPD have all significantly reduced, not as he mentioned by hospital-oriented changes, but by public health changes. And that is what I am going to dwell upon. Now, in this latest report given by the World Health Organization in 2013, if you look at the left half of this slide, it shows the low-income countries have the highest prevalence of non-communicable diseases amongst individuals less than 60 years as compared to the high-income countries. Sadly, WHO groups us amongst the low-income countries, although truly we do not belong to that. But anyhow, that's besides the point. Let's see the disease prevalence amongst us. We used to believe that these non-communicable diseases are diseases of the Western society. They actually are afflicting low-income, middle-income countries like ours to a larger extent. And today we have to change our mindset that these are the diseases which are affecting our population, and we have to make a difference. We have to handle these disorders. In this beautiful study, prospective urban-rural epidemiological study, the PURE study, now group of Salim Yusuf with some Indians, V. Mohan, Rajiv Gupta, some of them are members of the API, part of this meeting. They looked at the pattern of cardiovascular diseases across 17 countries. It's a very beautiful study after the Monica study, which was done only in high-income countries. And what they found, although the risk factor burden is lowest in the low-income countries that we are in, the rates of cardiovascular disease and the rates of death that we are afflicted with is much higher. So don't just look at the risk factors. See the affliction of this disease, the consequences that it causes in our population. And they also say the high burden of risk risk factors in the high-income countries is possibly being mitigated by their good control of risk factors, better use of pharmacological agents, maybe statins, maybe aspirin, maybe ACE inhibitors, and of course revascularization is much higher in those countries. Diseases, as I said, have been afflicting mankind in different patterns. 100 years back, we were living in the age of pestilence and age of pandemics. About 50 years back, the world started seeing diseases of the age of degeneration. And more recently, in the last 10, 15 years, we had delayed degeneration, and now we are having diseases related to the age of inactivity. And if I look at what is happening in my country, what you as physicians are seeing, we have diseases, the type 1, backward and rural, tribal India still lives in this particular phase of life. Most rural belongs to the second phase. Large parts of urban and rural India lives in the third phase. So we as physicians are treating conditions of all phases of epidemiological development. You are needing to treat infections, nutritional deficiencies, and now these non-communicable diseases, malignance. So you really and truly need to be empowered with knowledge that can handle all these disorders. Let's see how we are faring. Topic which is favorite with Dr. Devi Shetty, how we are doing in terms of medical health, how we can make it economical. We are going to have a panel discussion after this for 1 hour as to how we can give affordable health care to our patients. Dr. Bansal is going to compare this. We only spend 4% of our GDP on health, whereas some other countries spend much higher. We belong to the BRICS country group. They spend about 9 to 10%. 70% of healthcare is private oriented. We've been able to increase the longevity of life from 45 years when we attained independence to 66 years, which truly is a big gain, and primarily because of good hygiene, public care, and good care of patients that you and I are doing. But some of the health parameters need to be improved. Now, if I go to this very beautiful editorial by Srinath Reddy and David Hunter in the New England Journal of Medicine 2 years back, the UN has had only 2 meetings for health. They've been meeting for various other reasons, maybe climate, maybe politics, they meet every other day. But for health, they met first in 2001 for HIV, and even they are now realizing the impact of non-communicable diseases. They met 4 years back for looking at how non-communicable diseases are threatening mankind. And it is found today, I quote from this editorial, non-communicable diseases contribute 63% of total deaths. 80% of deaths in the conditions that you and I live, that is the low and middle income countries, are afflicted and people are dying of non-communicable diseases. And 80% of those deaths of non-communicable disease are due to these big 4, coronary artery disease, diabetes, COPD, and cancer. So coronary artery disease is the largest fraction of this non-communicable disease. The disease, as we all say, all physicians feel is epidemic amongst us. 9 to 10% of urban India, 4 to 5% of rural India is afflicted with this disease today. We have a 2-fold higher incidence than whites. We have a 4-fold higher incidence than the Chinese. Our plaques are very vulnerable. We have, for any given level of atherosclerosis, we have more coronary events than anybody else. So this increasing burden which presents in our individuals at a younger age, we have more acute myocardial infarctions, the disease is diffuse, it's more aggressive, and the mortality is 10 years earlier than some other races. So racially we have a more predilection to this disease. Why is it happening like this? We are all transitioning. We are moving. Rural India is moving to urban India. Urban India, so many people, we have now this August foreign faculty of 30, they've all migrated from this country. Similarly, IT, people are moving. Certain amount of acculturation, as Shashank said, my both daughters have migrated. So this acculturation which happens, this brings in a horde of risk factors which come to you. And we are all, we know, born with a thrifty gene because we were exposed to famines over ages, and our genetic makeup is such that we are not attuned to handle the high caloric intake that we are today exposed to. And over and above, there is this issue of early protein deprivation. We are born low birth weight Indians who are born low birth weight. They have higher prevalence of coronary artery disease. So there are very many factors. And 25 years back when I joined DMC, we looked at that time there was very meager data from rural India as to what the prevalence of coronary artery disease was. We were looking at where are we placed in the world scenario. And we published in the Indian Heart Journal at that time, the prevalence of hypertension was 14%, diabetes was 4.5%, and coronary artery disease was 3.1%. Subsequently, of course, we have beautiful data from our own country. We need not say we do not have epidemiological data from our country in terms of coronary artery disease. The National Statistical Survey has shown in very large percentage of studies across the country that the prevalence today is very large amongst us. Let's see how are we dying, how are Indians dying, what is causing death amongst our individuals. The million death study, Dr. Tejas Patel just dwelled upon this particular study. It started, the Registrar General published the data in 2001, and cardiovascular disease are responsible for 1/5 deaths of individuals. And more recently, the Government of India, Ministry of Health released this data. 30% of these deaths, mind you, are occurring in people less than 60 years. So it is truly afflicting people of a younger age. And we looked at this study which Shashank mentioned 20 years back. We looked at we grouped up with a group from London, George Sutton, Julian Kyle, and Deepak Bhatnagar, and we looked at 247 migrants who were living in London. We could find out their brothers and sisters living in India. So we really wanted a subset of individuals who were genetically similar, but they were exposed to very different environments. And we found that migration did cause an increase in BMI, cholesterol, blood pressure, but two things which are being quoted widely ever since, we found genetically we have a higher prevalence of Lp(a), which is a genetically determined lipid risk factor, and we also have increased insulin resistance. Brian William, in an editorial along with that study, he mentioned, and I quote from his editorial, excess diabetes and coronary artery disease in South Asians relates to the genetic factors of high Lpa and increased insulin. And he went on to predict that this could herald an emerging epidemic of CHD and diabetes in Asians. What he said 25 years back, we are seeing today and we are visualizing amongst our people. As you all know, and as he mentioned in this editorial also, it is an issue of whether it's the nature, we are born genetically prone to it, or is it the nurture? Are we living? Has our lifestyle changed significantly? Have we become more sedentary? Are we more stressed? Are we exercising less? Are we eating bad diet? What is the factor which is causing this increased factor? We know genetics plays a role. We know coronary artery disease is more common. People who come at young age, they have 2 to 5-fold higher prevalence. We know lipids are highly genetically linked and they are heritable. We also know from single gene Mendelian diseases that people who have these disorders, their siblings, their children have higher prevalence. So genetic role became more obvious once the Human Genome Project was completed in 2003, and gene-wide chip became available in 2007, and ever since we know that various genomic-wide studies have been done. But the South Asian genome had not been studied, and in this study we published in PLOS One, the South Asian genome was studied in 168 South Asians, and the whole exome we studied in 147. And we found some autosomal sequencing variants and single nucleotide polymerases we found which were peculiar to us, some pressure points in genes which are involved in metabolic disorder that we have, different infection patterns that we have. Skin cancer now causes 20 to 30% of malignancies amongst Europeans. Indians, it is only responsible for 1 to 2%. So obviously there are genetic differences that you and I have from this Western population. Our predilection to some infections, malaria, it's not just related to the hygiene, it is related to our genetic makeup also. And so also in atherosclerosis. We used to be told that there are some 200 risk factors for atherosclerosis. But this beautiful study, the Interheart study, showed us the 9 risk factors that are known to us still can explain 90% of the disease pattern that occurs. And let's, in the next 10-15 minutes, see what each of these 9 known risk factors are, how they are peculiar to us amongst Indians, and how they are responsible for this increased coronary artery disease. Hypertension, you all know 20 to 22% of Indians have hypertension. It is the commonest public health. Vikram Patel in an editorial in Lancet said 12% of health-related death is due to hypertension. It's the largest lifestyle factor which is responsible. Very many studies were available, but the Association of Physicians of India carved these Indian hypertension guidelines in 2001, released by the then Prime Minister, and now we are on to the third guidelines, largely due to the work done by some of our colleagues and stalwart Dr. Siddharth Shah, who initially started. We felt our geographical situation is different, ethnically we are different, our climate is different, we eat differently, we live differently, and obviously the guidelines for hypertension cannot be that we adopt from the West, because they have to be our own, because our people are different. And we did publish recently in Nature Genetic some of the markers for hypertension, and we could find 12 loci which are associated with hypertension, and we could find that DNA methylation is responsible. So different races are differently genetically prone to hypertension. I would like to quote this gentleman, Mohinder P. Sambi, who's donated $1 lakh to our institute, and we today run a hypertension chair and clinic. He feels that it's the epidermal growth factor which is responsible. And why I brought this for this beautiful line which he wrote at the end of a 14-page editorial that he gave in the Journal of Hypertension. I quote from him. Sadly, he died a couple of months after he gave this editorial. He says, if the role of EGF is confirmed, the hypothesis can answer many questions. If not, this will not be the first swan song of an emeritus to die its own death. So we need to look at hypertension in our own perspective, how genetically we are prone to it. We did this ICMR study in which we looked at office blood pressures, and we found that although knowledge is there with regards to how blood pressure needs to be measured, but our practices are not the same. So there is a disparity between our knowledge and practices which we need to change. Simple thing, mercury has almost been abolished in the world, some of these Western countries, as a blood pressure measuring instrument because of environmental pollution. We need to change some of these practices. Smoking. Now, Indians smoke very differently. In the Medicine Update book that we have brought out, some of this work on Indian pattern we have shown. Now, we have smokeless tobacco products like Khani, Zarda, Kivan, Gundi. So our people are living differently. Our people are eating, they are intoxicating themselves in a different manner. And we need to take in this history as to what they are doing. Just smoking, if you take a history, you will not be able to reach as to how much tobacco exposure your population is. So we looked at this data and we published in Indian Heart Journal. We found young individuals, smoking was the major factor. And these individuals, smokers, males, obese, they had myocardial infarction 7 years earlier than this. So this is one risk factor, especially amongst Indians and so also in other races in the younger ages. My friend Shashank, the chairperson, they did an ICMR Indiab study. Now, there are very many people in this who are co-authors to this. They found, and we all know ever since then, Indian pattern of dyslipidemia is different from the Western. Only 11% had high LDL, which is the major risk factor amongst the lipids. 13% had hypercholesterolemia, but mind you, 72% had low HDL. 30% had high TG. So our dyslipidemia, Indian dyslipidemia, is different from the Western dyslipidemia. Don't get complacent if you see LDL levels in the near range. Those LDL levels are even more harmful for us Indians. And we looked at in some of these studies, genetic studies that we published in PLOS One, we found chromosomal region 11q23 as a marker for triglyceride, and we found 10q21.2 as a marker for HDL. So today we are looking at areas in the chromosomal distribution which are acting as greater genetic markers for us. We all know increased CETP activity decreases HDL. Low HDL is a risk factor for us. And we all used to believe that niacin is very good for us. And so also we used to believe that this wonder drug torcetrapib was a beautiful drug. In fact, Indian physicians, you and I at one time thought this is going to answer the problem for us. But unluckily, this was a negative trial. There's nothing wrong with this drug. There's a recent DEFINE study which has been done with anacetrapib. We only genetically need to find out who are the individuals. We published this work in pharmacogenetics and genomics, in whom we will use this targeted therapy, which might be somewhat toxic, but we will be able to find out who are the individuals in whom it's going to be more useful. Unhealthy diet. This is the major factor that you and I have. I quote from Bhagavad Gita, as the food, so the mind, as the mind, so the man. So you essentially are what you eat. And we looked at some of our practices in school-going children in Ludhiana, and we found 5% of rural and 11% of urban school children had obesity, and this was translating to 3% of hypertension and 7% of hypertension amongst urban Indians. We are eating more trans fats, comfort foods. We have our own fast foods. We've changed the concept of McDonald's. We've made our own chili chickens are getting into the Western foods. And some of these trans fats, which genetically we were not attuned to eating, digesting, our metabolic systems are not so good to handle these fat intake, and that is what playing havoc. It's been studied that Indians who migrate, they start eating more fat. Although Indians living in India are primarily, we are a carb-eating society. And our genetic makeup is such that we can handle carbs. This excessive fat that we are exposed to, we are not able to handle this. And we found out, and thus we need to educate our people that they need to go back to the earlier Indian diet of high vegetable and fruit intake. And when we had the APICON in Ludhiana, we created the largest vegetable mosaic. And we could get it into the Guinness Book of World Records for the simple reason we wanted people to realize that our traditional food of vegetables, fruits, is much better than this newer diet that we are having. Lifestyle is another important factor. Almost 22% of IHD globally is related to sedentary lifestyle. And in the Indian migration study, it was found out. Shashank often calls it as NEAT, non-exercise activity thrombogenesis. So incorporate exercise into your day-to-day life. You may not spare time, but walk the talk. And this is what was shown. Walking and bicycling to work was associated with reduced cardiovascular risk. So this is something we need to tell our public. Diabetes is a very important risk factor. It's a factor amongst Indians which virtually explodes as ruralites come to urban area and as Indians go abroad. We've been able to find out some genetic markers, the CSNK2. We all know short telomere length is related to osteoporosis, hypertension, and this is a marker of short telomere length. It could answer some issues. There are 9 known genetic markers for coronary artery disease, and 4 of them were shown by us in Indians to be there. And believe you, these polygenic diseases have multiple genes. They don't have one gene. So possibly there are multiple genes, the CDC-CAM-KIT gene, the transcription 7-like-2 gene. So we are reaching a stage, we are finding out which, we published this work in Annals of Human Genetics as to which gene markers are peculiar to Indians. Stress, you and I, and so also the rest of the world, everybody in this country is stressed today. The life is moving at a faster pace, and it is responsible for a large part of coronary artery disease that we today have. William Osler said 130 years back, a keen and ambitious man, indicator of whose engine is always at full speed. This is another very important factor. Obesity, peculiar markers for obesity, which have also been delineated as to what is causing this. Now, more recently, we went back to the same population I dwelled upon. 25 years we went to these villages, Pohid, and we again went to this population. We thought, let's see. We cannot do a Framingham-like study. We are not funded that heavily. But why not see the same population? What is happening to those 3 villages? Maybe people are living differently. And this study, we found that CAD prevalence has increased from 3% to 5%. Diabetes has increased from 5 to 11%. Hypertension has increased from 14 to 29%. We might be, desi ghee is considered as a culprit. We are eating less desi ghee, but we still have high coronary artery disease. These refined oils are possibly not doing anything good to us. And the prevalence of CAD has gone up significantly in the last 25 years. A lot of us physicians believe we are a pro-thrombotic society. Yesterday, Shashank was telling it's a wintering effect. What is causing us? More blood carry, what is causing us? More venous thrombosis, more cerebral venous thrombosis, more pulmonary Dr. Devi Shetty did work on pulmonary thromboembolism, one of the largest studies. CTV, one of the largest studies. So what is causing this excessive at various sites amongst us? Now, I just mentioned shortly about this very excellent study, the CREATE study, published in Lancet 2008. We were not part of it, but beautiful study. It shows that STEMI is more common amongst poorer people. 70% of them have this. And STEMI more common amongst rich people. So the occurrence of these acute events, the triggers which are different from atherosclerosis are different. Rich have more diabetes. Poor have more smoking. Mind you, out of 170 hospitals, a large percentage of these were public health hospitals. Only a small fraction of our patients get coronary angiograms. Still fewer get PCAs and CABGs. Primarily because we found, again another study we did 20 years back, very few people are reaching in time, less than 40%. So public education we need to do. And sadly there is a mortality disparity. The rich have a mortality of 5%, poor have a mortality of 8%. So we need to bridge this gap. We need to develop our own consensus guidelines. And in this term, we thought maybe pharmacoinvasive treatment is best. We need to be creative. And this creativity is going to create a better future amongst us. And we need to find our own solutions. Better public awareness regarding the health effects, better food habits, reduction of tobacco usage, greater physical activity, use of mass media we can use, schools we can go to. If we really want to develop a shell around us, and this shell is going to be constituted by good social support, which you and I as Indians have inherited. We need to go back to the high oxidant diet that we have, exercise, less stress, and love. So I would say let's create this shell if we want to avoid being sad subsequently. And this sadness can be prevented by stress management, aerobic exercise, good diet control. And that's why we had this theme that we carved for this conference. Let's translate evidences into practice. We have a lot of evidence today. Let's translate into practices so that our people have lesser coronary artery disease, lesser people. Healthcare should be available, affordable, accessible, and acceptable also to our people. If we want to achieve this goal of universal healthcare, which Government of India today says, we need to change our healthcare systems to a larger proportion of people. Not only just the rich, but even the poor should have it. The government has realized this, and a national program has been started for control of non-communicable diseases. But we as physicians, you and I, need to look upon these non-communicable diseases. What has happened is affluence, prosperity has created a disease society amongst us. And how we can fight this disease society is by wellness education. Maybe you can develop wellness apps. Maybe you can educate people in terms of wellness, and that is how we can handle this disease. Thank you, ladies and gentlemen, for having a patient hearing.